welcome everybody. The Women's Health Research Institute would just first like to acknowledge that we are uninvited guests on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And as a provincial research institute committed to improving the health outcomes of women, including those across the 2S LGBTQIA+ spectrum, we recognize our responsibility in the collective effort towards establishing culturally safe healthcare systems and services that address health inequities among Indigenous peoples, especially Indigenous women, girls, and Two-Spirit peoples. And we encourage all people involved in research to read both the Truth and Reconciliation Commission of Canada Calls to Action and the In Plain Sight report, and reflect on the ways that we can incorporate the recommendations into our work. And as we gather in spaces together, we encourage you to reflect on your positionality on these lands and your personal commitments to reconciliation. So I am very pleased to be able to introduce our speaker for today's rounds presentation. Dr. Souvik Mitra is a staff neonatologist at the BC Women's Hospital and is an associate professor of pediatrics at UBC. He completed his fellowship in neonatal perinatal medicine and Masters of Science in Clinical Epidemiology from McMaster University, and his PhD in epidemiology and applied health research from Dalhousie University. His primary research interests revolve around improving patient and family important clinical outcomes of extremely premature babies with a patent ductus arteriosus. His current CHR-funded research projects include a pan-Canadian study on the comparative effectiveness of NSAIDs for treatment of patent ductus arteriosus in preterm infants, and a multi-center RCT on selective early treatment of the patent ductus arteriosus in extremely low gestational age infants. He serves as an associate editor for the Cochrane Neonatal Group, chair of the Fetus and Newborn Committee of the Canadian Pediatric Society, and is a member of the Institute Advisory Board, Institute of Human Development, Child, Youth, Health, and the College of Reviewers for CIHR. So please join me in welcoming Dr. Mitra.
Thanks a lot, Catherine. And thank you for getting us started in a good way here this morning. So just share my screen.
Okay. There we go. Looks great.
Perfect. Great. Thank you again for this warm invitation this morning, and for inviting me to talk about something that is very, very close to my heart. We often hear about these buzzwords in hospital care: evidence-based medicine, parental preferences, patient preferences, quality improvement, but we're often confused, including myself, that how does all these three come together, especially in a high-intensity setting like ours in the neonatal intensive care unit? Is it even possible for these three factors or things to coexist? And that is essentially the topic of my discussion. I do not have any conflicts of interest to disclose other than acknowledging that I live somewhere in the world of doing ultrasounds of the heart in small babies and the world of evidence-based medicine and synthesis with Cochrane Neonatal and the Canadian Pediatric Society. I am by no means a quality improvement expert. So at the end of the discussion, I hope that I would have raised enough questions that can stir a healthy debate among the QI champions that are present here in the audience. But as a clinician, like all other clinicians, I often wonder, what do we need to make a rational clinical decision? Is it just any good quality evidence? Or is it a combination of the following? One, what really matters to my patient? How trustworthy is evidence for benefit or harm with regards to what matters to my patient? Does this evidence really apply to my setting that I'm working in? And is the use of these interventions or policies even practical in my setting? And when I start considering all of these factors and start putting these together in my policies and guidelines, what I really get at the end is a clinical practice guideline that conforms to international standards. So with this background, I have essentially three objectives for my talk today. First, to explore what kind of quality improvement initiatives we employ in our day-to-day practice in the NICU. Do we focus more on doing the right things, or do we focus on doing things right? And we'll try and tease out the differences between the two. Second, we'll pivot towards guidelines and explore, do neonatal guidelines truly follow the principles of evidence-based medicine? What are these principles? And finally, again, we'll try and raise the question if guidelines created following these principles of evidence-based medicine bridge the gap between evidence-based medicine and quality improvement. Now, before I delve deeper, I would like to take a moment to acknowledge the tremendous contribution that quality improvement has had in the lives of Canadian newborns. Starting off with this landmark randomized trial back in 2009 that kickstarted this concept of continuous quality improvement through what we know now as EPIC, or evidence-based practice for improving quality. And I'm pretty sure a lot of people in this meeting today have been influenced directly or indirectly, or have been involved directly or indirectly with EPIC in their careers. Now, what we've seen through EPIC is that over the years, more and more centers have joined the bandwagon. And over the last decade and a half in Canada, we've seen a sustained improvement in most of the major clinical outcomes that affect newborn babies, which is a wonderful achievement. But if we take a look a little bit closer into all the sites that have participated in these EPIC quality improvement programs, we find that although there has been an overall improvement in outcomes, the results have been variable across sites. For some sites, the results have been great, with huge improvement in outcomes, while for some other sites, the results haven't been that good and even worse in some cases. And this is not surprising because different centers have different problems. As this graph shows, that across the centers, some centers are struggling with very high rates of severe brain injury in very preterm babies, while other sites are struggling with high rates of necrotizing enterocolitis, which is a devastating gut injury that afflicts extremely preterm babies. So therefore, when I look at this nicely laid out QI pathway by EPIC, I, as a person coming from the background of evidence-based medicine, what really intrigues me is how do QI groups engage partners and implement change when it comes to their quality improvement initiatives. So as I educated myself a bit more, I realized that to achieve your quality improvement aim, you need to identify your primary and secondary drivers. And through this process, you end up identifying your change ideas, which are the actual healthcare interventions that you implement as your QI guidelines or bundles. Now, what kind of interventions are implemented as these change ideas? Now, again, as a QI naive person to begin with, I thought that, well, these are the doing it right interventions that are specifically tailored to the local context to improve uptake of things that are already proven to work, or in other words, that are already evidence-based. But then I realized that, well, for outcomes to improve, you have to do the right things. So you need to use interventions that are actually proven to work. And when I look at some of these quality improvement bundles, these laundry list of interventions, I find that a lot of times, some of these interventions have absolutely no evidence base to it. So that got me even more thinking about, okay, how do people decide on these interventions? And as I educated myself a little bit more, I realized that, hang on, people have been fighting over it quite childishly over a long, long time about which one is more important, doing things right or doing the right things, which kind of makes me convinced that to improve patient outcomes, the two need to go hand in hand. And there's no question around it. Now, what are some of the doing it right interventions? Things like washing your hands, using mother's own milk in preterm infants. These are things that we know we should be doing, no question about it. But even for things that we know we should be doing, sometimes it is difficult to implement those things. For example, if we look at this nicely done QI project from Boston on improving mother's own milk use in the neonatal intensive care unit, they went through this very elaborate QI process to identify a number of barriers that took them a lot of effort to mitigate and ultimately improve this quite obvious and very simple thing of improving mother's own milk use in preterm infants, which tells us that it is hard to do the right things. And that is why, again, I would like to kind of take a moment to acknowledge the tremendous work that all the QI champions are doing every day in the hospital to improve the quality of care in the respective units. But the EBM skeptic in me still wonders that, are we sure we are doing the right things in all the QI projects and in all the QI bundles? Because having been involved in some of these projects at a local and a national level, I find that a lot of work goes into brainstorming causes, choosing local priorities, mapping the process. But when it comes to implementing these change ideas, I'm not so sure. And I'll give you a very interesting example of this widely cited randomized trial from the NICHT group in the United States that was published back in 2007. This was a trial that was a cluster randomized trial that was done to improve rates of survival-free BPD or bronchopulmonary dysplasia, a form of chronic lung disease for extremely preterm infants. They randomized 14 centers. 7 were allocated to usual practice, essentially means do whatever you are doing without any guidance. And the other 7 were asked to choose from a list of potential best practices identified from the best performing sites in the United States at that point of time. So interestingly, what they found was that in the smallest babies, born less than 26 weeks of gestation, yes, there seemed to be an improvement in their outcome of survival without BPD. But contrary to expectations, the outcome of severe brain bleeding, severe IVH, was significantly worse. Now, that led to a lot of debate and discussion about why did this happen? And there has been publications on this. But if I look at this long list of potentially best practices, I cannot help but wonder that did these centers really choose the right things to do? Now, agreed that this was done in 2007, so we have to put that in the context in terms of what evidence was out there. But if we look at some of these interventions, and our neonatology colleagues would kind of agree with that some of these interventions, like prophylactic use of surfactant, we don't use it right now. Lower oxygen saturation goals, proven to be bad. Limited intravenous fluids, an aggressive approach to patent ductus arteriosus treatment doesn't seem to work. So it again raises the question that if you're not doing the right things, then doing those things right, does it really matter? Now, the third aspect of this is, what if we are sure we have nailed it. That is, we have identified the right problem in my center, and we have narrowed down an intervention that is proven to work to improve that problem. So what do? We then go ahead and implement that change as a standardized NICU guideline or a practice bundle. But the question is that what if these changes are against the parents' values and preferences, especially in our province, in our country, where parents are coming from all different social, demographic, cultural backgrounds? How much do we spend time in exploring whether our practices, even though they are strongly evidence based, how much do they align with the parents' values and preferences, especially critical care interventions? Now, we in our neonatal world take a lot of pride in promoting ourselves as proponents of patient and family centered care. But for some reason, when it comes to critical medical decisions, this whole concept is thrown out of the window. A doctor walks into the room and says that, well, we are going to give this drug to your baby to protect your baby's brain, or we give this drug to protect your baby's lungs, or we routinely start antibiotics here in your situation because it's standard NICU policy based on evidence. And now acknowledge that in today's world, when modern medicine is delivered by increasingly complex healthcare teams, there is a need for standardization because the scope for practice variation is wider than ever before. And you and I both know that there has been lots of publications that talk about the benefits of standardization. It promotes the use of best research evidence, decreases practice variation, increases efficiency, which in turn improves patient safety and care quality, making healthcare more cost effective, and in turn helps to improve the clinical outcomes, or at least those outcomes that we as healthcare providers think are important. And therefore, it is not surprising that we all have been brought up and taught in a world where the goal of a policy or a practice guideline solely has been standardization of care and reduction of practice variation. But the question is that doesn't that directly contradict our philosophy of providing patient and family centered care? And this is probably the reason why you and I, at some point, have conveniently deviated from our policies and practice guidelines for the benefit of the patient in front of me or the family in front of me, and have shrugged it off saying that, oh, it's just a guideline. Haven't we all done that? Now, if you and I have all done that at some point, maybe it's time to think a bit closely about the phrase practice variation. What are we really trying to achieve here? Now, I would argue that what we're really trying to achieve is cut down on unwarranted clinical variation. Variation that stems from lack of adoption of evidence-based practices, lack of technical expertise, interventions that are solely based on providers' needs, preferences, and biases. But on the other hand, shouldn't a guideline have the flexibility of promoting some degree of warranted clinical variation, variation that conforms to the local practices, the local logistics, and also, most importantly, the patient's needs and preferences? Now, if we all can agree that, yes, a purpose of a quality improvement initiative or a guideline should, on one hand, try and cut down on unwarranted variation, but promote warranted clinical variation, doesn't that directly conform to the basic principles of practice of evidence-based medicine that had been quite eloquently defined by Dr. Dave Sackett back in the 90s as a combination of these three main pillars? One, the relevant scientific evidence, which in very simple terms, as I've mentioned, is doing the right thing, things that are proven to work in the context of the local clinical practice, that is doing it right in your local context, and considering the outcomes that actually matter to patients and families. And therefore, any clinical guideline or practice bundle that has not considered these three pillars is not practicing evidence-based medicine, regardless of how much they advertise themselves as proponents of evidence-based medicine. Now, one could argue that these concepts were developed in the adult world, where things are very different. These concepts all apply in office-based family medicine practice. But do these concepts really apply in neonatal care, which is a very, very different field? So from some of my own work in the next few minutes, I'll try and explore. Again, I said that I don't have the right answer, but I'll try and explore if these concepts may be applied to our field. And I'll use the example of the use of a drug called indomethacin, which is an NSAID, that is variably used to prevent morbidity and mortality in extremely preterm infants. Now, I've intentionally chosen a topic that has a lot of evidence base to it. Yet, there is a huge practice variation across the country. If you look at the use of prophylactic indomethacin, to date, almost 5,000 babies, extremely or preterm babies, have been randomized in clinical trials of patent ductus arteriosus prophylaxis. And these are just trials that have been published and have made it to the Cochrane database. Out of this, more than 3,000 babies have been randomized to trials of indomethacin prophylaxis. Now, what we know from these trials is that indomethacin does a fairly good job of closing these tiny little blood vessel called patent ductus arteriosus that connects the two major blood vessels coming out of the heart. And in turn, that helps to reduce fluctuations in blood flow in the brain, and which leads to reduction in severe brain bleeding. It was also hoped that this would have an impact on the lungs by causing less damage to the lungs, by increased blood flow to the lungs. But the trials did not show that, did not show this effect. On the other hand, there are concerns that NSAIDs, like indomethacin, would be detrimental to the gut and the kidneys of these very small babies. But nevertheless, because of its impact on the potentially important outcome of reduction of severe brain bleeding, a lot of centers have routinely gone ahead and adopted the use of prophylactic indomethacin in their quality improvement bundles. So I'll give you two very recent examples. If you look at this paper from a couple of years back from University of Alabama in the United States, they created a QI bundle for reduction of severe intraventricular hemorrhage in their extremely preterm population, and routinely introduced the use of a single dose of prophylactic indomethacin, in addition to a number of other potentially best practices, and showed a pretty impressive reduction in not only severe IVH, but also the composite of severe IVH and death, because we know that both brain bleeds and death go hand in hand. Now let's look at another similar example from UCSF California, where they also introduced the routine use of prophylactic indomethacin in all micropreemies born less than 25 weeks, and most extremely preterm infants between 25 and 28 weeks who remain dependent on mechanical ventilation for the first few days after birth, in addition to a number of other practices. And they demonstrated more than a tenfold reduction in severe brain bleeding and cut down their death rates by half. Now, these are just isolated um, success stories, but this does not really reflect what is happening across the United States, where over the years there has been a steady reduction in the uptake of prophylactic indomethacin across centers. And if you look at Canadian data, it paints a very similar picture. Though in the last 5 years, there has been an uptick because of increased incidence of severe IVH. Now, this has happened due to valid concerns around nephrotoxicity, effect on the kidneys, effect on the gut, and also the fact that the largest randomized trial that was interestingly done in Canada, that along with a number of other centers, that though it showed a reduction in severe brain bleed, it failed to demonstrate an improvement in long-term neurodevelopmental outcomes. So clinicians felt that, well, if it does not really affect long-term outcomes, why bother? Now that leads to that was kind of the history of use of one prophylactic agent. Now, in recent times, there has been emergence of other competing prophylactic agents. So, for example, if we look at this widely publicized QI project from the United Kingdom called the Periprem, that was designed to reduce morbidity and mortality in extremely preterm infants, they again nicely summarize a long list of potentially best practices that includes this drug called hydrocortisone, which is a steroid drug, but interestingly does not include prophylactic indomethacin, despite all the evidence that has been accumulated through years of randomized trials. That leads to a very, very important question. Why do we differ in our clinical opinion, even if we are reading the same evidence? Now, there could be a number of reasons. We are all busy and we are not up to date on recent evidence. But at least I think that given now that evidence is disseminated in multiple different formats, not only print, but also electronic, social media, all of these websites are doing a great job of keeping us up to date. I think we are fairly up to date on at least the most important recent evidence in our field. Second, it does not apply to my local context. Yes, very valid point. I recently came to learn that indomethacin is not even available in several centers in England. So if it is not available, there's no point in even putting that in our QI bundle regarding like no matter how much evidence is out there. Third is the rather sensitive topic. Do we really understand the evidence that we are reading? And I have doubts. I have doubts because of the number of times I see decisions being made solely based on p-value cutoffs, making things clearly black and white, without a lack of appreciation of the magnitude and the certainty of effects in relation to clinical decision thresholds. Something I'll come back later in my talk. And finally, even if we acknowledge that yes, we are all up to date and reading the same evidence. It applies to my local context, and I've managed to understand the evidence correctly. Even then, interventions have differential impacts on important outcomes. And what's important to me is not important to you, and we never even ask parents what's important to them. Therefore, decisions, guidelines, and policies all end up being made on how we as healthcare providers value outcomes in our local context. Now, the question is, if we take so much of pride in promoting ourselves as proponents of patient and family-centered care, and we want to work with patients and families rather than just do things to or for them, shouldn't critical QI initiatives factor in how families value these outcomes? Now, one could argue that yes, we absolutely involve parents from family councils in our QI meetings as we create these guidelines. But I would counter argue that is that enough for all interventions? Again, I'll go back to some of the work that we have done on creating a guideline on prophylactic cyclooxygenase inhibitor drugs in extremely preterm infants, and specifically explored this conundrum of prophylactic indomethacin or prophylactic hydrocortisone to kind of highlight some of these concepts that I've been trying to bring up in this talk. So our project essentially had three main objectives. First, we compared all prophylactic cyclooxygenase inhibitor drugs using network meta-analysis that we published in Cochrane Neonatal in 2022. Second, we had the opportunity to present that evidence to the families to evaluate their values and preferences, and we included families of extremely preterm infants and also adults born extremely preterm to find out how they perceive this evidence. And finally, we formulated guideline recommendations using the GRADE evidence to decision framework. And we will kind of talk a bit about how this concept of GRADE helps us to conform to the principles of evidence-based medicine. And when we published our work on the final guidelines, we ensured that the author list does not only consist of healthcare providers, but we had parent representatives, adults born extremely preterm, actually contributing to the paper. Now, a lot of you might know about GRADE as a system to rate the certainty of evidence, but it also helps us to move from evidence to a decision or a recommendation. It essentially has three steps. First, we formulate the question and, most importantly, select what outcomes matter. And here, right at the outset, we involve all the stakeholders, including patients and families. Then we curate the evidence on these selected outcomes through systematic reviews and rate the certainty of evidence for these selected outcomes using standard GRADE methods. And finally, we use the GRADE evidence to decision framework to move from the certainty of evidence to the strength of final recommendations. So in our project, we ensured that stakeholders were involved early. One, to ensure that the process was fair and transparent. And two, to ensure that we have considered all important outcomes that are critical for our decision making. So, as I mentioned, our guideline panel not only comprised of neonatal practitioners, but also epidemiologists who are methods experts who had nothing to do with neonatal care, pharmacists, and most importantly, two parents of former NICU patients and two adults who were born extremely preterm. They declared their financial and intellectual conflicts of interest, which is extremely important. And then we did a preliminary survey of these panelists to come up with the 7 most important outcomes that we think would drive our final decision making. And that included severe brain bleed, death, lung disease, GI outcomes, surgical PDA ligation, and neurodevelopmental impairment. And these outcomes essentially form the basis of our Cochrane review. Now, what we realized through our years of doing Cochrane evidence synthesis is that it is not only important to identify what outcomes are important, but also delve a little bit deeper and a priori define what do we mean by a meaningful benefit or harm. because that's where a lot of variation comes. What's meaningful to you may not be meaningful to me. And again, I don't even know what's meaningful to the family. So what we used was what is called a partially contextualized approach, which has been recommended by the grade working group as an established method of identifying meaningful benefit or harm. So using this approach, for each of these outcomes, we identified and defined what we mean by a small benefit, a moderate benefit, a large benefit, large harm, moderate harm, and a small harm for each of these outcomes. And as you can imagine, a small change in magnitude of death could be very different and could equate to a large harm compared to a small change in magnitude for a much less important outcome, such as a GI bleed. And it was very, very important to differentiate the two. And as I mentioned previously, when we have this black and white approach based on if it works versus doesn't work, based on p-values, we completely lose sight of this nuance that we actually use in our clinical practice. Now, having defined what outcomes matter and how much do they matter, then we rated the certainty of evidence on these outcomes using this grade methods. Now, I'm not going into the details of these methods today, but just to give you a summary, when we have evidence from randomized trials, we take that as high certainty of evidence. We have more confidence in those estimates. But then we look at sources of bias, such as risk of bias, inconsistency, indirectness, imprecision, whether there was publication bias. And in addition, for network meta-analysis, where we're combining data from different studies and looking at indirect comparisons, we look at intransitivity, which is if we could at all combine these different studies and these different populations, and whether there's incoherence in our estimates, which means that whether our direct comparisons and indirect comparisons are vastly different. And then we kind of look at all of these in totality to come to our final certainty of evidence, which could be high, which means that we are very confident in this evidence, or which could be downgraded to low or very low, which means that we are less and less confident in the evidence that is presented to us. And this is important because this has direct implication on our final recommendation that goes into that laundry list of recommendations or QI bundles. Now, what we found in our own study for indomethacin, we found that there was moderate certainty of evidence to suggest that there was a moderate reduction in death and a small reduction in severe IVH, moderate and small being predefined based on the consultation with all the different stakeholders. There was low certainty of evidence to suggest that there may be a small increase in chronic lung disease, but we were uncertain. While we found that, at least from randomized trials, there was fairly high certainty of evidence that there was no increase in these GI complications. So now with this evidence, we then presented it to families using a cross-sectional mixed method study. We did the study in two phases. One, a pilot feasibility study, where we kind of learned from and modified the study based on the different logistic challenges, and then moved on to the formal values and preferences study, where we included 40 participants, mostly adults, mostly parents of extremely preterm infants, in addition to 9 adults who were themselves born extremely preterm, that ensured that the median gestation age of the participant or the child at birth was 26 weeks. That essentially ensured that every participant has had a lived experience of neonatal intensive care. Now, there are two parts to this study. First, we asked participants to rate these outcomes on a scale of 0 to 100, 0 being the least important, 100 being the most important. And then we summarize these outcomes, these results. Not surprising, death came out to be unanimously the most important outcome, followed very closely by severe brain bleed. Interestingly, chronic lung disease, which is arguably the most commonly used primary outcome in contemporary randomized trials, was actually rated way down on the list, which again shows that there's a huge disconnect between what parents think is important and what we think is important and use them every day in our clinical trials to make decisions. So, having known what's important to families, then we presented the evidence on these outcomes using infographics such as these, which I created using the Magic app, a software that is freely available for you to try out. We summarized the evidence for all these outcomes and then asked the parents a simple question that based on this evidence from the best available evidence to date, whether you would choose this drug for your baby. And then we repeated the process for all the families and summarized the results. Now, interestingly, what we found that completely contrary to existing practice, majority of the participants said that I would absolutely want to have this drug given to my baby, especially given that it reduces this very, very important outcome of severe brain bleed and possibly reduces death. And that trumps the slight increase in risk of chronic lung disease, which was quite striking to us as researchers. Now, next, to make things a little bit more complicated and realistic, we presented them with the evidence on hydrocortisone. We got the evidence from a recent individualized patient data meta-analysis that demonstrated that when hydrocortisone is given right at birth, there was moderate certainty of evidence that there could be a moderate reduction in chronic lung disease and a fairly large improvement in survival without chronic lung disease. But there was a catch. The catch was that both indomethacin and hydrocortisone cannot be used together because if they're used together, the risk of gut perforation requiring surgery is 2.5 folds higher, which we cannot let happen. So they had to choose one or the other. And interestingly, we found that when hydrocortisone was presented as an option, two-thirds of the participants who had initially said yes to indomethacin flipped their responses and switched to hydrocortisone because they felt that the mortality benefit was way higher compared to the IVH benefit, while a third still chose to remain with indomethacin because they felt that reduction in brain bleed was still their most important goal. So what all of this tells us was that there's a huge variability in how families value these outcomes in this context, and therefore we cannot standardize the use of one drug or the other if we have to follow the principles of evidence-based medicine. So we brought all of this novel information back to our guideline panel to create the final recommendations. And here we used the evidence to decision framework. Now, this table outlines the different domains or components of this framework on which the panel members have to provide their judgments. Now, what this framework allows us to do is not only consider the best research evidence, but put that in the context of family values and also forces us to consider the local context, which often gets missed, such as local resources required, local health equity issues based on the local demographics, and whether your interventions are culturally acceptable and feasible in the local context. Now, once the panel has considered all these different domains, they are put together to come to a final strength and direction of recommendation, which could be either strong or weak, or strong for or against the intervention, which means that the benefits clearly outweigh the harms in most situations across most populations, or the recommendation could be a weak one, which means that the balance could tilt one way or the other based on either differences in family values or differences in local clinical context. So, coming back to our own question, the panel felt that the scale probably slightly tilted in favor of indomethacin given its definite reduction in severe IVH and probable reduction in death. The scale could have tilted squarely in favor given the strong parental preference for its use when presented as the sole option. But given the fact that a lot of patients or families rather switched their preferences when hydrocortisone was presented as an option, tilted the scale slightly back in balance. So considering all of these, the panel finally made a weak recommendation in favor of using prophylactic indomethacin in extremely preterm infants at the highest risk of severe brain bleeds, the highest risk being defined based on local demographics, with a strong emphasis on shared decision making with parents to evaluate their values and preferences when possible before making a decision. So, after all that elaborate exercise, essentially for this topic, the most evidence-based recommendation was talk to families before you decide. Now, how does that even help my colleague who has been asked to come up with this laundry list of interventions to prevent severe IVH in their own unit? And this is a very, very practical problem. So let's just try and run through this problem in using some of the numbers from our own center. So what I've done here is I've pulled the data from the Canadian Neonatal Network. The bars in blue represent the rates in our own sites in our own site, whereas the bar in orange represents the rates of these outcomes across all Canadian centers. So on the left, we find that the rates of death or severe brain bleed in the micropreemies have been steadily increasing and have gone higher than the national average in the past couple of years, while the rates of death or severe BPD have been fairly stable, maybe slightly below the national average, but are still pretty high. So, if we consider our local rates, should we include prophylactic indomethacin to prevent IVH as a priority, or should we go ahead and adopt prophylactic hydrocortisone to prevent death or BPD? Now, here is what I would pose a question to my QI champions and colleagues, that instead of routinely adopting or discarding an intervention in a QI bundle, in these situations where the most evidence-based recommendation recommends shared decision making, why can't we make shared decision making itself the change idea? So can we have a future of quality improvement that aligns or conforms with the principles of evidence-based medicine, where when the most evidence-based recommendation mandates shared decision making by care teams, we make offering the opportunity of shared decision making the process measure, thereby promoting warranted clinical variation that we talked about, and where interventions are clearly shown to have a benefit, such as antenatal steroids, surfactant, caffeine, we go ahead and standardize those as NICU policy and use and track their implementation using standard QI methods as a process measure, thereby reducing unwarranted clinical variation. Something to think about and consider, and I would love to again have feedback from QI champions on what they think about this approach of combining the QI methodology with the concepts of evidence-based medicine. So in conclusion, I would like to wrap up with one of my favorite cartoons from Paul Glazo on this concept of leaking evidence to practice pipeline, where to improve clinical outcomes, we need to start by doing the right things. That is, we need to start by identifying the interventions that are actually proven to work through research. And then we need to identify if we can at all apply that to the local context. Are we able to act on it in our local context? That is, we have to do it right locally. And while doing it, we have to continuously ensure that we have considered family values at every step of the way. Are we considering the right outcomes in the right context? And this concept of developing evidence-based clinical practice guidelines using the GRADE methodology that nicely brings together these three pillars might help you achieve your quality improvement goals in the most evidence-based, family-centered way. Thank you. I'll stop here and I'll be open to questions and comments. Thank you so much again for listening.
Thank you, Dr. Mitra. That was a fascinating and thought-provoking presentation. So if anybody has any questions, you can go ahead and unmute yourself, or if you want to pop a comment in the chat, I'm happy to read it out. I see we have some NICU folks in the audience. I don't know if there's any QI champions that want to take up Dr. Mitra's ask for some debate.
It looks like there's unanimous agreement in the proposed approach.
Rosie, go ahead, ask your question.
Thanks, Dr. Mitra, for a really excellent discussion of nuance and complexity. I really loved the distinction between warranted and unwarranted clinical variation, and also the consideration of the variation in family values. It was just so well done. Maybe I'm a bit naive. I was wondering about how hard it is to implement shared decision-making in the NICU. What do you see as the barriers and facilitators to that?
That's a very good question, and that is something that I think we always talk about every day on rounds, and when we come up with interventions to implement. Now, for me, the biggest barrier is time. Parents in the NICU are already stressed. They have a very limited cognitive bandwidth. A lot is going on in their lives. So if a decision is time sensitive, it is very difficult to impose that on the families. And we actually, I didn't have time to present that, but in our study that we published in JAMA Network Open, we did explore that a little bit, asking that, like, would you even want to be involved in this decision making at all? Now, interestingly, what we found that 55% of the respondents said that absolutely, I would want to know what, like the nuances of the benefits and harms, but since too much is going on in my life, I would defer it to the doctor. 35% said that I would absolutely want to be involved in that actual shared decision-making process, which told us that 90% would at least want to be offered the discussion. So that was our biggest takeaway, that at the very least offer a discussion, and then say that, well, we have a tentative recommendation that has been made through this process where we have involved families, we have involved physicians, and we came up that in the absence of your input, this will be our default, but we would still like to have a discussion because based on your input, that default could change. So, so that is kind of my my thought process regarding the barriers. But I would also mention that there are a lot of interventions like right now in the NICU where we could possibly use that approach, but we are not using it. I don't know if that answers your question.
Yes, that was great. Thank you. Yeah, and I really like the idea of offering as the process outcome.
Any other questions? You can raise your hand or pop it in the chat, or just go ahead and unmute yourself and ask. Maybe I can just follow up on Rosie's question and just ask, what do you think the barriers, or what would need to happen to kind of get that culture change where shared decision making may be more feasible in the NICU context?
I think the one thing is that we have to educate ourselves a little bit more around evidence, the concept of evidence itself, and we have to learn to live with uncertainty, because I think that that's something I find, having worked in a number of different NICUs, worked with different healthcare providers, everyone wants a yes or no answer. Tell me what to do, and I'll stick to it. If I deviate from it, that is not standard of care. And that is something we have to kind of move beyond that a little bit, because healthcare is not that black and white. And it kind of applies to a lot of different things. And there is this idea that any deviation is bad. So those are some of the things that we have to acknowledge, that since there is uncertainty, some deviation is actually good and warranted, because it means that we are committed to that individual patient's needs, and there is actually better healthcare. Whereas we cannot use that as an excuse to deviate every time, and deviate from practices where there's no reason to deviate. So that is the culture that we have to talk about, inculcate to like within our trainees, our other allied health professionals. And again, I think that is one of the futures that we can really look at.
That's great. And I see a question came in the chat. So Miriam, thanks you for a wonderful presentation. And considering the variations in values and preferences, I'm wondering, what are the top family preferences when it comes to the NICU? I don't know if you're able to answer that directly.
Yeah, so it depends on like it depends on a number of different factors. Families in general want to be involved, at least informed to begin with, involved in decision making, definitely when it comes to low risk interventions, feeding practices, skin to skin care. Those are some of the things that families absolutely want to be involved. When it comes to more critical decision making, I've seen there is variation. Some families would say that is way beyond my bandwidth. You are the doctor, do whatever is important to my child. But at the end of the day, every family, or at least most of the families, want to be as involved and informed as much as possible. In terms of your question on what are the top priorities, it kind of depends on the different stages of their child's journey in the NICU. In the early phases, very critical child, depends on the intervention that we are using. I want my child to live. And I think that's the most important thing that has come out in most of my discussions with families. All the outcomes come later, but I want my child to live. And therefore, we need to keep that in mind when we select interventions, because sometimes that kind of goes down on the list, and when we get ourselves entangled in all other different outcomes. So yeah, so kind of bringing us back to what are the topmost things that parents want, brings us all back to like a shared goal when we are managing patients in a multidisciplinary team.
That's great. Any last questions? So I do see one question in the chat here. from Nicole, see such an alignment with implementation science. What message do you have for the research community and how they can enable evidence-based medicine?
Yeah, thanks for that. Thanks for that question. I think there's a huge disconnect between implementation scientists and researchers and us clinicians, and I think that's why we come up with and that's why there's a huge lag between generation of evidence and its actual successful implementation. We come up with this nice ideas, we talk about it in our within closed doors, and then bang our heads against the wall that why aren't people using it. So I think if we have to have one message, we need to collaborate more with implementation scientists, involve them in our QI projects, invite them into our world, have them join rounds, and kind of co-create these guidelines and policies, because I think a lot can be done in terms of uptake, which I'm not educated in implementation science. So I would want to learn from education, like implementation scientists, on how to implement these ideas. So would love more collaboration with these folks.
That's amazing. And I think that's a really great note to end on. And I see we've come up to the top of the hour. So I just really like to thank you, Dr. Mitra, for a astounding, thought-provoking, nuanced presentation. I think it gave everybody a lot to think about. So thank you so much for sharing this with us this morning.
Always a pleasure. Thank you so much.